Good morning and a warm Friday welcome to all those around the world joining us today for Intravascular Imaging Live, our new and exciting live series from the CCC Live Case Series, broadcasting as always from the Cardiac Cath Lab at Mount Sinai Hospital in New York City. I'm Nitin Barman, your moderator for today's session, proud alumnus of this lab and current Cath Lab director at Mount Sinai Morningside. So today we're very excited to present our fourth case in the Intravascular Live Imaging series, the second to highlight OCT imaging and the first to intersect with physiology-based decision-making in the lab. As always, the main purpose of this series is to demonstrate the value and technical execution of intravascular imaging from a fully practical point of view, with the hope that this will translate into more appropriate utilization in our audience's practice. So with that said, let's get started. As always, we'd love to hear from you in our interactive chat, so please send us your questions right from the website or to YouTube. I'll be monitoring the chat throughout the session, and please know that your participation definitely adds value to the program. The full case will be posted on our website, www.ccclivecases.org, as well as our YouTube channel in the next day or so. So as always, if you're unable to see today's program in its entirety, definitely check it out in the archived form. As mentioned, we have a great fourth case for you today. So with that, let's head over to Dr. Kinney and the team in the Cath Lab at Mount Sinai Hospital for today's live case presentation. Dr. Kinney?
Okay, good morning, Nitin, and good morning to all our viewers. Myself here, Dr. Kinney, and Amit Huda, who is going to be assisting me. We have our fellows, Akash Patel and then Monica Karki right here. And of course, we have Kiski, who is going to be working on imaging with us. We have Will, Alina, and our tech is Asif and Habib. So having said that, we're just going to show you, let's start with the case presentation. So nothing to disclose as per the disclosure. So as mentioned, this is our fourth case. So we have this 49-year-old patient who actually presented few weeks ago to his cardiologist with some symptoms of angina class 2. And then since he was young, we always know the indication at that time would be right now, most people are going for direct CTA. So he had CTA done and positive FFR. So young guy, but he has hypertension, hyperlipidemia, and strong family history of CAD. So you can see that. So because it looks like he has already been on a primary prevention on statin since his LDL already is 67. So CT scan, you can see 3 vessel CAD. Okay, calcium score of 644, and calcium was seen in almost every vessel, and significant FFR in all the, especially in LAD, circumflex and RCA. So he was on aspirin, rosuvastatin, as well as medication for his hypertension. Then he came for a cardiac cath, as you can see then. So we're going to show you. So cardiac cath also showed 3 vessel disease. So see a proximal RCA, just extending long lesion. I'm going to show you that into the mid RCA, moderate proximal LAD about 50%, and significant mid LAD after the 2 diagonals, and distal circumflex lesion. So syntax was just about 15. Since non-diabetic, low syntax, EF is normal. This is a case that can appropriately go into PCI. So the plan would be he had successful RCA PCI, and today would be physiology as well as imaging guided PCI of the LAD. So we in our lab, we always go through this exercise of making sure the patients who are referred even after cath or CTA that the PCI is appropriate. So if you see here, patient did have symptoms only on one anti-anginal, but more important is that FFR was positive, in which case by all criteria it becomes an appropriate case. So this was his RCA. So significant disease before the RV branch, and then a little more like a moderate 30-50 just after the RV branch. So we put one long 48 millimeter stent, and that's how it looked after the procedure. So stable case. So what we did was he went home on just Plavix, and today his PRU is 53. Just some of the slides we are going to repeat so that we recap why IVUS and why OCT. So in this case, if you want to do a imaging guided lesion understanding assessment, you could do both IVUS or OCT, but we are picking OCT today. Resolution, as you see, much better. Pullback speed is also way better. So in a matter of 2 seconds, you are able to get almost 76 millimeter of the vessel, and you understand what is going on. Though the new Avigo IVUS can go up to 8 millimeters per second. The main important reason where OCT helps is two things. One is to understand fibrous cap thickness, which is very rare, not so much so for management, but if you get a non-obstructive, non-QMI, and you want to understand is it the various kind of the lesions that you want to understand, then fibrous cap thickness measurement can only be done with OCT, and we have gone through this in our last case, that you can see calcium in IVUS, but more important is to understand the true length and the thickness. Thickness can only be measured with OCT. So these are the two important points of OCT, that fibrous cap thickness to understand whether it is plaque rupture or erosion, because the treatment is different. You have a patient that comes with a non-QMI and non-obstructive lesion, you see some erosion, that there is a disruption of the plaque, you can leave the patient on medical therapy. So that kind of decision making, and of course understanding calcium thickness. So this is important. Again, I'm showing you, why I'm showing you this is because we are going to do OCT after this, and people should understand what we are looking for. I know Kiski is going to tell us all the lesion characteristic, but I think our goal is we ourselves have to understand, is it true what we are looking at. So we are going through the same thing again, and this we published. This is from our lab here, that came out in 2017. So how does a fibrous lesion look like? Fibrofatty lesion, see, wow, you see that thin cap, and then when you see the back scatter and high attenuation, that means it's all lipid. So that's what you're seeing, and of course, well delineated border, that means it's calcified lesion. So these three things I think we have to understand and keep it in our bed cells. We are going to show again how we prepare the OCT catheter. So most of the time, the operator, if you are very comfortable, you can do everything by yourself on the table, or if you have somebody like Kiski in your lab, which is rare one to find, that we will he just manages, he does the pullback button himself. So preparation wise, I think Amit is going to go through, very important, 100% contrast you need. You flush the, that 3 drops should be dropping, or still you feel the resistance. Today I think there are few key points we will make during our live case. When and how can you safely do OCT? So you can do hand injection, but you will need a larger syringe, at least 20 cc, and you have to make sure you have good, the finger strength to actually inject. But these 4 P's are important. Position the catheter distal to the lesion. Okay, once you are there, you purge the catheter lumen to make sure all the blood is removed, and this is the key point that we have put. Puff to evaluate the clearance. If you do not see that there is clearance of dye and you don't see a distal flow, it is telling you the lesion is very tight. Do not inject. Okay, because you see that the major complication, which even major papers have said, and also we have it in the guidelines, that risk of ventricular fibrillation. So very important, the puff to evaluate the clearance. If you do not see clearance, do not inject or do not do the OCT. You can remove it and then maybe do something else. And of course, then you do the pullback for image acquisition, because that is what you need. The image acquisition and the rate with what it is done, you see that there. So it is about 2 seconds or so, you get 75 millimeters of the vessel evaluation. Today, because of the, you know what, now let me just go back to the angiogram. So let me show you the angiogram first. Go back.
That was a great summary. I know viewers have seen this before, but I'd stress the point that obviously in the world of education, the important things get repeated, and understanding those points, how to differentiate which tool to use and how to do it is fantastic. Thanks, Dr. Kinney.
So now you see that EDP was normal, EF is normal. Like I mentioned, he's on Plavix with the PRU of 53, and look at our previous stent. Looks good. The key for this person would be to make sure his LDL is under control, less than 55. His LDL is 62 now, probably needs a little bit of Crestor 10. We are going to increase that after this. So look at his left. You see that distal circ? And more important is today, this is a vessel of choice. So the Prox LAD before the first septal, 30-50, you see some maybe adventitial calcium. And after the two diagnosed mid to distal LAD, you can see significant disease. So this is why I think this is of our interest, that FFR is positive. But when you see disease like this in a young guy, the question is, do you do physiology guided intervention, or do we do imaging guided intervention? So in imaging guided intervention, we definitely have certain guidelines for IVUS guidelines, but not so for OCT. So our goal here will be, we will do IFR, and that's why I'm going to show more slides why we picked IFR. And we will do the distal LAD stent. We'll do the IFR, then we'll do OCT. We'll stent the mid to distal LAD, and then we'll decide what to do with the proximal lesion. Let's go back to the slide now. So coronary function test, which has now taken the most important point, where every guidelines and every live case, there's a lot of importance being paid to physiology, and I think you can have a whole day session discussing the various trials that have been done over the last 10-15 years for us to come to this level. So we are going to focus today on just epicardial assessment. So epicardial assessment, which is there, if you see here. So the previous slide, let me go back to the previous slide. Whoever are watching, if there are, because for the fellows it's very important, this question comes in the board asking for epicardial, microvascular, and what part, how much of the myocardium, and that percentage that is in the bottom. Very important, you have to know these numbers, and this is being asked in the boards. So going back to epicardial, which is not a lot that we see of the epicardial vessel. So we have FFR, IFR and RFR, and there's something called QFR that they use in Europe also, which you may see some slide. So this is the key point of today. So when we are doing FFR, we use an hyperemia. So you got to give some adenosine that works on the vessel, that dilates the vessel, and you are getting a pressure gradient in the proximal vessel, okay, which is closer to the guide. That is why when we are doing FFR, you have to make sure the guide is disengaged, okay, and then distal to the lesion. That difference of the pressure that you're seeing is what we are measuring. And there's a lot of studies saying that, outcomes are also based if it's positive. And now we go to resting index. Why resting index is important? So there are two resting index, IFR, which is called as instantaneous flow reserve, and RFR, resting full cycle ratio. So you need to know the difference. Once you know the difference, you will know why I think probably IFR is more important, and a lot of studies have come with the IFR. And look at the number. The FFR is 0.80, IFR will be 0.89, little different. So if you see the RFR, so you have the aortic pulse, then you have a dicrotic notch. Just after the dicrotic notch, you see what's called as a resting cycle. Okay, that is why it's called as a resting full cycle ratio. But what it does, 1 point, the maximum difference between your wire and the aortic pressure, at 1 point it gives you a number. So that is RFR. These questions are being asked in your board exams. Why? What is the difference now with RFR? So you have the dicrotic notch, you finish that, and then we have to see the wave free period, which is the blue one. And that difference that you see there, and it will take 4 to 5 points and then give you a number. So that is, I think IFR probably is more reliable than you taking one single point, which is the RFR. So you can see what the differences there it is. So going to how you should do this, very important. If you don't do it right, again you'll have wrong numbers. Okay, very important. Proper guide engagement. Once you have proper guide engagement and everything, give nitro so the vessel is all good. There cannot be air bubbles anywhere in the system, and remove the introducer. That's a important point, that remove the introducer and equalize. Okay, the transducer is at the distal tip, equalize and then go forward. And this question again comes, gradient or a drift. Another important point that I want to make. What is the difference? You see the gradient, the dicrotic notch disappears, it becomes like a damped pressure, and you see a gradient between the aortic pressure, that is the guide, and then the green one that you see will be from the wire tip. So very common, and if a mistake happens, you see a drift. So how do you know a drift? It looks like the two pressures are just move. One is in the bottom, one is on the top. That's it. The dicrotic notch is still there. So this difference people have to know. And how do you know for 100% it is right? Do a pullback, and when you do the pullback, when you come closer to the guide, it has to come to 0. So once you say FFR is positive after your hyperemia, right? Pull back, and you have to make sure you're back to 1. So do not just stop after you say, okay, FFR is now 0.71. Do the pullback, make sure it is true. There was never a drift. So this is the point that we are going to show there. And today, why are we picking IFR or RFR? Because studies, and there are a lot of publications to say that if you have hyperemia, the interaction between the serial lesion cannot be 100% true. So what you need to do is the resting gradient. That is why when you have a tandem lesion, like we see here, you got to do the resting pullback. So you see, when you do a resting pullback and you see a difference in the gradient, you know it's focal. It's rare you get that focal, okay? Most often you see is the tandem or diffuse. Today we are likely going to see this, which is the tandem. And now the question comes, when you see something like that, how do you make your assessment? So the biggest drop or the change is what you will stent first, and then you have to repeat it to understand is the IFR positive again, and if it's still positive, then you have to take care of the distal lesion, do the IFR, then do the proximal lesion. So in a diffuse case, which is often what we see in diabetics and other patients, it is difficult to know. You try to see if you can find a definitive gradient. So if you see here, both AHA and ESC guidelines have made the physiology as class 1 indication right now. So very, very important. When in doubt and you don't know, do you need to take care of this lesion or no? Intermediate, the symptoms are not clear, intermediate non-invasive testing, and CT scan is positive, but FFR was not done. You got to do invasive FFR because guidelines are all showing it there. So now we will go to the case again.
Another great explanation. I mean, I think it's a widely used tool, but I don't know if all that use it understand it to that level. So that was a great review of what really is a fairly complex subject. So very helpful. And just how to technically get the correct values so that we have high fidelity data and our decisions
Can we
from that.
change here to IFR so we can show the IFR? So we're going now, okay. Okay, nitro and everything is clear.
It'll be interesting to see how much is related to that proximal lesion.
Yes, very, very important. I think it will not be a lot. We'll probably, what do you think, Amit?
Yeah, I think proximal may not be, but the mid definitely looks quite
So
similar.
very important, where are you going to do your equalization, right? Before any lesion. So I'm out of the guide, you see that? So even when you're doing equalize, flushing, giving some nitro, I'm removing the, can you show the ceiling camera? We are removing the needle introducer. You can see it, right? No, I'm showing
No,
this.
it's
What
we
happened?
can't see it right now.
Frozen.
Huh?
This is obviously a really important step. I think. Yeah, we have you back here.
Okay, good. And now can you, so you saw that here. This is the only time maybe I'll be using a torquer, okay?
You can show this. You can show this.
Because these wires don't listen, and you want to make sure all these connections, everything is maintained. Yeah, good. Now we do use, can we put the IFR on the screen? Can you show it there in the bottom? No, there. Just like imaging, put that.
I'll make another quick
yeah.
point.
Oh, nice.
No,
No.
top. Instead of imaging, the same thing.
I'll make a quick point while they're doing that. Especially with the Philips device, it's important that little cassette, that white cassette there, is handled relatively gently. That's where the connection of the wire is. So, and it can loosen and give problems there if you don't handle that with some care. Still not having the physiology screen.
No.
Why? No, if imaging is happening now, this is why this is not showing. No? Cannot?
Okay.
Now, why he cannot show it?
Okay, can you show that indirectly? Yeah.
Yeah,
This is the curve.
we got that now. It's if you could zoom out just a little bit, we could see the numbers as well.
Okay, do your
Yes.
equalizing.
Yeah, we do equalize.
Maybe the camera operator could pan up a little bit so we could see the oh, there we go.
Okay,
Now
good.
Yeah, there
1.0.
we go. Beautiful.
Okay. Now I'm going to go back with the wire introducer.
You could even see how the IFR goes up to 1.04 just by introducing the
Yes.
artificially lowering the guide pressure. Yeah.
Run through ready for OCT. Okay.
See, torquers aren't all bad, Dr. Kinney.
Hmm?
I said torquers aren't all bad. It's going.
They're not
very
all
well.
bad? I
No.
don't know. Somehow my fingers not used to it. It's all how you train. Okay, so now I'm distal because if you see, there's a bridge also just after the lesion. You know? Okay, now
Yeah.
we are ready?
Yeah, 0.85.
Everything
Yeah, positive.
good, right? It's positive.
Flush.
We know that.
I flushed earlier.
Okay, good. We are good. Okay, go back, show us. So it's 0.8.
Yes.
So wait for a nice stable 0.80, 0.79. Okay, good.
Yep.
So the number that you remember was 0.89. So we are 0.80.
Yep.
So now we are going to do the pullback. Okay. So let's go to the pullback mode. You're there? Okay, good. So I'm going to start doing the pullback slow. So this is the distal edge of that significant disease.
Yeah.
Look at that.
Huge drop.
Yeah.
I'll come back to 0.95.
And of in the island between, it's almost normalized before
Mm.
crossing the
Yeah, we see
proximal region, huh?
Second drop, but
Yeah.
like a small drop. The first drop is the bigger one.
Okay. Okay, Kiski.
Yeah. So
You
I
tell
think
us.
we can call it tandem.
So that is that big jump, right? Based on your number, which is 0.03, definitely that was the biggest. 0.80 to what? It became like 0.91,
Yep.
right?
Yep.
Yeah. And then we close to 1. When
Yeah.
I pulled back, it was like 0.98, 0.99.
So yeah, accurate assessment.
No
Yep.
drift. Yes. So we're going to keep this wire in the side. And let's take care. Now let's do the OCT, understand the plaque morphology and understanding how we take care of the lesion length. And then we go back, clean this, keep it with you.
That was a great demonstration of the pullback. You want to wait for the blue line to kind of settle, and then a nice controlled pullback, stopping at the location of interest between the two tandem lesions, essentially where the proximal edge of your distal stent may land.
So now we will do the OCT. You want to show them how you prep the OCT, Amit?
Yeah. So though we have it prepared, but we can walk you through the steps.
Can we
with
show the ceiling camera? Now we go back to imaging. Change it. Change this.
We have a question from the audience. It's not exactly on this system. It's a question about some other systems. How does the AngioFFR from CathWorks fit in here? I don't know if you want to address that, or I can.
Yeah,
give
you
my 2
can.
cents.
Yeah, make your 2 cents, but
Yeah, I mean, I think the point here is that there are likely to be multiple tools that assess physiology, and what we want to see is validated data, and certainly then a kind of other variables enter into the equation with respect to cost and how different labs function. But I think obtaining this just from the angio there's a certain appeal to it. But from my end, I would certainly like to see more in terms of validation. I also don't know the product that well, having never used it, in terms of how it handles situations like this, tandem lesions, etc.
I have seen the system, but like you mentioned, I'm not sure whether it has been validated. Okay, now let us go with the OCT. So we can show, yes, connect here. We are going to be using, if I can show so we are going to use assist here, okay, to do the OCT.
Habib, that's okay. No, what?
Remember the 4 P's, okay, that we just said.
Another question about the FFR or IFR. Do you disengage the catheter tip out of the vessel in the aorta, or just at the proximal left main for your initial equalization?
Just a proximal left main. When you are doing that, suppose many time what happens is, it could be there is some disease in the left main or that area. That time you may have to disengage, but not really, just proximal. Because if you disengage, you will lose the wire again, right?
Yeah.
When the wire is distal to the lesion, then you may have to disengage just to make sure the...
Yeah, I think some of the initial trials mandated equalizing in the aorta, but that's practically challenging in certain cases, especially radial, I'd say, where you
Yeah.
often need the J-wire. I think the key point is to really pay attention to your pressure tracing when you engage. And if that
Nice.
tracing changes at all, then,
Now it cross the
then you should
lesion.
equalize with the guide in the aorta.
Now we have a 4P
Okay, now I'm doing the first P, right? You see that?
positioning.
Good.
Yeah, this is second P.
Oh, second P, good.
Yep.
Then third P, which is the most important,
Yes.
right?
Yep.
I'm on the cine. Let us say not cine. I see that. Yeah. So you see some clearance, okay?
Yeah. Actually, not perfect. Yeah.
Okay, good.
Because of the tight stenosis. Yeah. We
Okay.
can try.
You don't see it well. Okay, go.
Okay, 1 second. Enabling. 1 second. Calibrating. Yeah. Please, cine, inject.
Doesn't
Okay.
seem like it's, oh, there we go.
So we can get image. Can we try again, please? Because of the
No, I don't think.
Okay.
You think it's too tight there?
It's
Yep.
too
Dr.
tight.
Kinney?
No. Believe me.
Safety.
I
first.
was
Thank you so
almost
much.
waiting for some changes. No. This is risky business. I still took a risk. We should not. It's barely clearing. Barely clearing. So that's one of the, pitfalls, OCT. Why did you think it did not happen?
Because of the distal stenosis, it didn't clear perfectly the distal point, but we got some image.
Yeah, that's enough.
Yep.
So it's mostly fibrous.
So I show you. So
Change to
this is not a good angiocorrelation, but this dot is the level of the camera.
2520, yeah.
So this is the tightest part of our like a second lesion.
You see that,
Lot of
barely any
plaque.
clearance.
So
Yeah,
much
and
plaque.
it shows like a eccentric, and this is also fibrous because there's no attenuation. We
to
can see the media. So this is a mostly fibrous lesion. Yeah, this is also concentric fibrous plaque. And based on the
2520.
sizing, I go to the distal reference. Yeah, here's a good perfect normal landing zone. I check the EEL and the lumen sizing, but the good vessel we can measure the EEL, but actually it's less than 2 to 5. The EEL to EEL is 2.1. So distal vessel size is 2.1 vessel. Even a 2 to 5 we can put like a gentle pressure.
Wow. I took a 2.5 balloon, but you are able to get us a lesion length or no? Because at the level of D2, did you come there? Because based on my eyes, OCT eyes, we were thinking we'll put a 2.533 and cover the second diagonal.
Yes, once again, yes, so I see the diagram here. It's not a perfect image, but I see here the distal landing zone to the D2 is 22 millimeter. If you cross over to the proximal, it's gonna be like to 28 or something. If you want just ostial, I mean just after the D2 stenting, 23 is fine. So if you want to cover, cross over that D2, maybe 24, 28.
28.
Yeah, I would go for longer as well. Could that distal reference diameter be a function of the how tight the lesion is in terms of a little underfilling?
That's a problem. It's not going.
Yeah.
He's saying that the distal. Were you able to see the bridge that we see it on the
Bridge point of view. So this kind of first pullback, we cannot see the
Nothing.
Dynamic changes like diastolic and
Okay,
systolic. If you want to see the dynamic changes, slow
14,
pullback
16.
IVUS is better.
18.
That's a 2.520, Dr. Kinney?
Yeah. We went up to 12 atmospheres. I think it's good. If you want key, you want us to do an OCT now after we dilated?
Yeah, we can do.
Okay. So I don't want to do another angio. Let us just do an OCT.
Sounds good.
So go back to the slides so we can. Can you get me a new Y connector? It's not working. How to do the stenting If you can show the slides again.
Yeah, we have that strategy slide up.
Yeah, I see. You have?
Yeah, although we lost your live fluoro, but
Okay, yeah. So, Kiski, go over that slide.
Yeah, so this is the basic of the stent sizing based on the intravascular imaging. And today we focus on the OCT. First we should find the normal landing zone. Normal means the largest lumen with the plaque burden less than 50% and no lipid and no calcium. Because if there is a lipid or calcium, it might cause the edge dissection. So first we find the normal to normal. And for this case, I found like a 2.2 Bessel. And next one is a stent sizing. Diameter should be based on the distal reference because the Bessel is a tapering. And there's a two algorithm based on the EEL sizing or lumen diameter. That's based on the plaque morphology. If we found a normal landing zone, we can measure the EEL sizing. Like if the average of the EEL is 3.1, we can size down nearest 0.25. It's gonna be 3.0. That's the recommended stent sizing. But if we don't find like a good landing zone, we measure the average of the lumen diameter and size up nearest 0.25. Then final stent length should be the proximal to distal normal landing zone. So that's like step 1, 2, 3 for the imaging-based stent sizing.
So what we will do is once we do the OCT, okay, then we can talk on based on what we see, how you will give the stent size, which is diameter as well as the length. I mean, if at all we are doing imaging, I would go just not with EEL, just with the lumen. That's what I do. What's your strategy, Nitin?
yeah, it's similar. I also, to be honest with you, a little old school, and I'll take into account, some of the demographics of the patient and the specific anatomic segment. For instance, even in this case, I'd be a little reluctant in a male to put a 225 stent in that mid-LAD. But I think the important thing is also post-imaging, regardless of which stent is used, or which strategy, rather.
We had some issue with the Y connector. Okay, so now I had to rewire it. Yeah.
Yeah, hopefully it's
Okay.
not dissected at all. Yeah.
Okay, some
free, yeah.
some it's going okay. Okay, good.
Beautiful.
Okay, we'll go with the OCT now.
So now that we have some better flow, you're going to repeat the OCT?
Yes. So
Wonderful.
that because our goal today also is to understand the sizing. How can you stent sizing? Because this is where I think a lot of questions we get is how can you do the stent sizing based on imaging? Old school people like us, we use the eyes and we do our image, but we need to, the newer generation want imaging guided, and we need to teach. Going with the OCT die.
Yeah, I think most of the value resides here in the stent execution. Obviously deciding to do the procedure is largely clinical. Of course, some imaging as you've discussed, but
So you close the lesion.
Okay.
Yep.
Flushed. This is the second P.
Yep.
Okay. Third P. Still not a lot of
Even the
clearing.
angio is a slow flow.
Huh?
Yeah, better. But okay, I changed to the manual pullback mode.
Okay, change
trigger.
to manual. Okay.
Yep. Do you try?
Yes.
Okay, enable. Can I enable? One
Yes.
second. Enabling, calibrating. Yeah, cine, inject. Did you see it?
Okay. No. Oh. Didn't go through?
yeah, it's tough putting through the manifold and the...
What?
It's coming back. 1 second. Yeah. Okay.
It's good?
Yep.
It's working?
1 second. 1 second. Please not perfect, but we try. 1 second. Enabling. 1 second. Elevating. Yeah, cine, inject.
I think you're.
Well, we
Yeah.
see the pullback without the floor. It looks like
Yeah, you can take it out. It's
the images proximally were better.
yeah, correct. Because we did a manual trigger this time. Automatic doesn't work. That's kind of tight stenosis.
So can you just describe that a little bit further for the audience? That means that you'll determine when the catheter gets pulled back.
Yes, because I
the
also
system.
see the angio, and if the proximal lesion is filled, I hit the button of the start pullback.
And it'll pull back regardless of its sensor.
Yes, that's the manual trigger pullback. Yeah.
You still can't see well.
Yeah, no, distal lesion we cannot see because of the tight stenosis,
We pre-dilated.
but still very tight. You see, yeah, I see some like a plaque, like intimal dissection, but still area is like very tight.
Okay.
But this time, good point is we got the proximal lesion. Yeah.
I think the other key point, and I know you mentioned this earlier, was to really make sure the guide is well engaged, or maybe even deep seated.
Yeah, so I think we can discuss this proximal later, but based on the distal lesion, I think the initial pullback was better.
Okay, let's just go back to the eyes, human eyes.
Can we see it? Is there an
Okay,
angio after the
2533.
balloon?
Yeah.
Yeah.
We did not.
But
Yeah.
Okay, we
again,
thought we'll avoid
No,
multiple pictures. Okay, let's
so
go back
Dr.
to.
Kinney, we have an initial pullback that showed the distal
Ready?
reference vessel size is like 2.3.
Go. I think we need to put across.
Longer. Yeah, I think across D2 is it's
33.
hard by our eyes. Yeah.
Okay, let's go. 2533.
I mean, I think even this is really important to. You're using multiple data points to make a decision. I mean, obviously the imaging is central to that, but. And it does look like that the bridge might be a little more apparent now in this picture. I don't know what's your distal landing zone right at that microseptal.
Yeah.
We have a question also for Kisuke. What's your baseline settings for OCT, e.g. apposition, 80% or more, etc.?
You mean the assist
Okay.
setting?
Now some die.
I'm not sure of this question here. Maybe I'll get some clarity.
Assist setting is actually the
Good, right?
4414
Oh, you want more? See
and
that?
450
You needed 38.
and 0.
Some die. That's a bridge. So I'll pull back a little bit.
I think so.
Okay. Okay. Go up now. Yeah,
Yeah.
that's good.
12 atmosphere.
Okay, get the IFR ready. So what's the proximal? What is your cross-sectional area on the
Yep,
OCT?
I'll show you. So we have a good image for the proximal on the second one.
Okay, ready?
Yeah.
Yeah, actually, around this septal and the D1 bifurcation, we see a little bit calcium, like eccentric calcium. And the
Very close to
tightest
proximal,
cross-section area is going to be like 3.1.
Rio.
3.
What are you saying? Proximal?
Yeah, 3.1
Oh.
cross-section area with eccentric calcium, but not severe calcium, like mixed plaque. And some part has a lipid plaque. You see on this cross-section, like 6 o'clock to 9 o'clock, we don't see the media. This is a attenuation. It means this is a lipid plaque. And some cross-section has well delineated border plaque. That's Dr.
Let's
Kinney
post
mentioned. So this is a calcium.
Give
So,
me a 3O balloon, 15.
yeah, mixed plaque, lipid and calcium, and tightest area 3.1 at the level of the septal.
You need to add 1 if you're converting it to IVUS.
Yeah, there's a slight discrepancy, like less than 10%, because OCT is more high resolution. We see more detailed information about intima. So the area based on the OCT is like smaller than the iris. So it means like maybe around 4 or something, 3.56.
So the proximal part of the stent we are going to dilate, okay? Okay, good, cop.
And you're taking a 3.0 diameter
Yeah,
balloon for
yeah,
that?
yeah.
That makes
18.
Okay, good. And now let's do the IFR, which probably will be okay now, right? Go low here a little bit, not a lot. Yes, not a lot. 8, yeah, good.
10 now.
Okay, down. We'll repeat the IFR now and then OCT.
Yeah, I'd expect it to be a little bit more abnormal than it was on the pullback, but I'm not sure that it'll be less than 0.89, but then we can still discuss, you know.
So right now, what we are going to do, one is that we are going to leave the run-through wire and then use the IFR wire. So it may not be truly. We are good? Huh? P1. Change it.
Yeah, that's a great point. I think that, you know, it's helpful to get this information, but we don't want to remove that wire after so much manipulation.
Is good? Yeah, okay. Okay, again, same thing. I'm going with the introducer and then equalize when we reach.
We have some more questions
And
here.
I will go to the distal part, distal edge of the stent. Yeah, what are the questions?
They're a little bit off topic, but still kind of in the conscious. How does DCB fit in here? And are you concerned about a stent fracture in the bridge?
DCB where?
Yeah, it wasn't clarified. I think.
You mean in that tight lesion? Native vessel?
It wasn't specified.
I mean, a DCB for a small vessel, yes. You know, there's a definite, I think, the current, based on the current data, probably ISR, small vessel, maybe side branches.
I think side branches is a good good use potentially if kind of
Okay, go.
a way to avoid.
Now it's 0.9596.
No, equalize.
Yeah.
Okay,
Yes,
good.
equalize.
Hold, now let me go. I mean, the proximal lesion, I think it is still moderate. We are going to decide based on the IFR now.
Obviously, the second diagonal lumen is okay.
Yes. Wire still going there. I think the anatomy of the vessel is such.
Yeah.
It's just going.
The
So I
angles- the
will have
angles
to
are
go to the distal edge of the stent.
Yeah, I get much below that. You'll get some reading from the bridge.
Yes, that's a key. So I think I'll just stop here. Agree?
Yeah.
That's the distal edge of the stent, a few millimeters below. Okay. Wow.
This is interesting. Yeah. The pullback will be quite interesting. Yeah.
Okay.
Yeah. It was 0.80, now 0.86.
Okay. We did something. You know what? Let me pull back really so we don't know. You could never see the
Yeah.
bridge, right? You could never see the bridge. Let me just come back. Okay. Okay.
Yeah, I would
See
set
that?
it there.
I think that was a bridge.
I
You see,
agree.
I pulled back just to the distal edge of the stent. You see that?
Yeah.
Yeah.
Now it's 0.923. Yeah, it's
You see that?
negative.
Good.
I think that's a really important point. We used to joke if you put the wire far enough, it'll be positive, but you know, you want to really distinguish what's contributing.
So you pull back.
Yeah, I'm going to do the pullback again.
Yep.
Then we have to compare the pullback. The jump we
Yes.
saw probably doesn't exist now.
0.9190.
Okay, hold on. I'm pulling back now. Slow pullback. Are you on the pullback mode?
Yes.
Okay, good.
9091. Yeah, this is
was
Okay,
Yeah,
now, yeah. See the flow. Now I'm at that, distal to that proximal lesion.
To the
You see
proximal
that?
lesion. Already 9.5.
Yeah, already 9.5. So you did see the little,
Jump in
Jump?
the stent.
yeah.
Might
That
merit
is
some
after
more
post.
dilating. Yeah.
No, we did post.
I
now
don't
come
know.
back
Did
to
they,
the
maybe the
9.8.
distal part of the stent.
No, I didn't want to go distal part because we're closer to the bridge.
Bridge,
So
yeah,
we are
no.
close to 1. Yeah,
So come back to 0.98.
yeah. 9. Okay.
Like minimum drift.
We all know your middle name is safety, Dr. Kinney, and that's an important point. Dilating adjacent to bridges can be tricky sometimes. So
Yeah.
well, I guess the post imaging will be also.
Now we
help,
can
yeah.
do the OCT and see
Yes.
exactly what has happened.
Yep.
I don't want to go to the distal edge. Let's see. We get the OCT now. Can we do it with the hand? What do you think?
Yeah, you
Rather than
can.
assist.
I think now with the stent, you should be able to. Right?
So now we do OCT. Now we do OCT. Yeah, thank you.
So now you're saying the proximal lesion, there is less than 1 quadrant calcium,
Yes.
but there's lipid plaque.
Yeah.
Yeah, like a combination.
Yeah.
Like,
So
but I measure the fibrous cap thickness. It's 0.16. It's not thin cap.
Okay. No, I know. So I think very important, this guy needs a very aggressive lipid
Lots of medicine,
therapy.
yeah.
So Crestor has to go up, and definitely LDL has to be not 55, maybe even 50.
I would shoot for well below that. Yeah. In a 49-year-old. Such burden of disease.
Okay, check the image.
Okay, now let us see.
Yep.
You pushed?
Yeah.
Yeah.
Yeah, good clearance because you open.
Okay, let's go.
Okay, 1 second. Enabling, calibrating. Yeah, please cine, inject. Okay.
No, I can tell you.
That is not coming. 1 second.
Let me do it with.
1 second.
Why?
1 second.
It's working or no? Huh? Okay, repeat it. Now, what was the issue?
No, it was refilling actually in the middle.
I said do it with hand.
Assist has a mind of its own.
Okay, good
Yeah.
clearance. 1 second. Enabling, calibrating. Yeah, cine, inject.
There we go.
Yeah, beautiful image. You can take it out. Okay. This takes time. Yeah, accept.
See this, the distal edge of the stent is, I'm sure, on everyone's mind as well. Yeah.
Mm.
First, we try the angiocorrelation.
So
Thinking.
you just dropped two pins, right? Proximally and distally.
You have to tell them how to do core edge and all that.
Case key, let's
Case
maybe,
key.
yeah, review
Yep.
that again.
We did quickly. So, can I show the distal stent? So this is a distal
Yes.
like native vessel, very small vessel. Now come to the stent, like a strut and a shadow. But there is no distal edge dissection. We should see carefully. There is no hematoma, there is no flap. So distal edge looks perfect.
Perfect, yeah.
Yeah, oppose. Then this is the intrasand. Yeah, there's some flag behind. The area is like 3.1, but this is a small vessel.
But more important, the stent is fully opposed.
Yeah, oppose on the plaque. And we cover that D2. Okay, this
Little-
is the
little
proximal.
malapose.
Yes, correct. So from the 3 o'clock to 6 o'clock, there's some malapposition because there's a size gap. I can measure the distance. Yeah, but it's less than 0.4, so we can call it minor malapposition at the proximal edge.
So the proximal part of the vessel. So we went with the 30 to 22 atmospheres. So tell us, when can you leave a malapose stent by?
Yeah, the major malapposition should be more than 0.4 millimeter. But
Is there an arc? Because look at the number of struts. It's almost like 2 quadrants.
Yeah, but the data shows just the distance of the maximum distance
Okay.
of the strut and the wall. But
Can you
it's
measure?
less.
Can you measure it there, Kisuke? Maybe at 3 o'clock, on the
Okay.
clock face. Yeah. Yeah, the middle orange dot, maybe.
1 second.
That seems like that's more than 4. Yeah,
Correct.
1.4. Yeah.
If you stick on this, it's gonna be measured malapposition.
What do you think?
Yeah, so if you want the post dilatation, you can measure the lumen size. The
But look
Long-
at the other opposite side.
Yeah.
It's into the vessel. Right?
the proximal lumen is 3.0 vessel. If you want to perfectly oppose, just like a gentle pressure with the 3.0 balloon.
No, we did 3022.
But still some malapposition here.
Okay.
If you
Then
think
get us
it's
the
a major.
30 again. But we're not going to repeat the OCT.
Yeah. But the point is the proximal edge of the stent has some eccentric plaque.
Okay, now go back to proximal LAD and tell
Lesion,
us
yeah.
what do we do.
Yeah.
Sure.
Based on the physiology, we can leave it alone.
Yeah.
Agree? Everybody agrees?
Yeah.
I think that's very clear. Yes, but
So again, this is a proximal lesion. The area-wise, it didn't change, like a 3.6, 3.5. And I see some eccentric calcium, and some part has like a attenuation, it means the lipid plaque, but not thin cap, like thick cap lipid plaque, and the calcium. But IFR negative.
Can you go back and tell them how to do the co-registration?
Oh, sure.
Okay, go up.
So we can go the lead correlation.
Okay, down. I'm going to pull back a little
First,
bit outside.
just after we got the image, come to this screen,
Okay,
we hit
go
the
up here.
confirm. Then I put the 2 dots, proximal and distal. The first dot should be the proximal, like close
Okay,
to the
down.
guide catheter. So I hit here. It said P. And the second one is going to be the distal end of the vessel. I put here. It says
Good, right? Take it off.
distal. And there's some vessel overlap. So we can correct here, like edit mode. And put 1 dot. Yeah, now it looks perfect. If you agree, I confirm. Then it's thinking. The easy step, like
That's-
proximal, distal. If there's some error, we edit and confirm.
very
And now we got-
user-friendly. Yeah.
Yes.
Ready?
So it worked. If there's some like a vessel overlap, there's gonna be some limitation. But this case, it correctly worked.
I mean, I think there was quite a bit of value add from this post OCT on both ends of the stent. I think angiographically, I don't know, Dr. Kinney, your thoughts. The distal edge was a little bit bothersome, but the OCT really gives you reassurance.
Yeah.
Ready?
And proximally, obviously, I don't think I would have posted again.
Oh, no, we did. We did post it.
Yep.
Because, because that's what studies have shown also. The most of the time is the proximal edge, because people are worried you're coming out of the vessel wall. Look at that. Now, looks good, right? Diagonal looks okay.
Beautiful.
Patient is fine, no chest pain. Good. Okay. So always, let's do a caudal picture, right? To make sure our left main and prox LED looks okay. I know we've done imaging, but that has to be the part. So we were ready,
Beautiful result. Yeah.
depending on what we were going to see. Go back to the slides now. Slides.
It's a great finish there. Not an exceptionally technically intimidating case, but really thoughtful decision making along the way.
Okay, this is what we showed, but I think what this MLD and Max is what the company is telling us, which we went through: morphology, length, and diameter. How we decide, right?
Yeah.
We went through, but people can use EEL or lumen. I like to use lumen if at all we use imaging, and then go up. So if the guidelines, again, we like to go over and over with the guidelines. Like we said, now it has made lesion severity assessment. In the past, everything was procedural guidance. Procedural guidance was 2024 ESC for complex lesion, which were left main, true bifurcation, and long lesion. So I think we did fit into long lesion here. Long lesion means anything that's more than 20 millimeter. In 2025, the ACC-HA made it for management of ACS, and there also they mention left main and complex. They do not define what is complex lesion, but for first time it has come to lesion severity assessment, but that's only for the left main, that you can use imaging, and that too it is 2A, and it is the IVUS. So this is the number you need to know, that it may come in your board exams, that it is safe to defer PCI if your MLA is more than 6. Remember that number 6 for the left main. And this is just if we were going to we want to leave the proximal lesion alone, but there has been one trial that was present in 2024 prevent trial, where they used 4 criteria after using the VH IVUS, where they used the MLA plaque burden, whether it was, they used NIRS to understand if there was a LCBI greater than 315, or TICFA, which I think you showed us TICFA, right?
Yep.
Based on that, it fits into the prevent criteria. Yes, but we are not practicing that right now. It did not make it to the hard end point, but definitely what it did was prevent PCI and reduce MACE, but never made it to the hard end point of death. So several other trials are ongoing for stable CAD, ACS, as well as in acute MI, that this kind of intermediate lesion, should it be done, and see what is the difference for the hard endpoint. So until those trials have any good, all the results are there, and we need to know exactly what the outcomes are. For time being, when you see this intermediate lesion, so 2 things, both based on imaging as well as on physiology, this lesion can be left alone, and we got to optimize his lipid lowering therapy. So we have 3 quiz to finish. So which of the following is not likely to cause ACS? You understand? Not likely to cause ACS. A, B, C, D. My fellows, are you guys ready to answer? So C, good. The C was that it is a non-eruptive calcified nodule. We've gone through this last time. So eruptive calcified nodule looks like that in the bottom. So the rest is all, you see that plaque erosion which I mentioned. Remember why you need to understand what the thin cap versus thick cap, you can see. So these are the various pictures. That's why I keep saying is that we have our OCT app or Octade. Download it and keep going through this images over and over again, so that when you are doing this imaging, you are able to understand what you are seeing. The second one is that the independent factor for periprocedural myocardial infarction. What do you think it is? So 62-year-old female, past medical history of diabetes, hypertension, stable angina, is referred for angiography, and 80% stenosis of the LCX. Operator decided to perform coronary stenting. Pre-intervention OCT showed below. What do you think? What do you see there? Look at the, we went through that, thin cap. Yeah, you see that? Yeah. So that is that. So we went through the criteria, right, for the prevent prospect. Which one do you think is not the criteria? C, because it has to be 70%. Yeah, so these are the criteria. That 70% you need to also remember it is from prospect. So that question can come in your interventional board exam. So remember that number. Good. And what we also have now released is a hemodynamic. We have the website ready, but the app will be coming soon. All what we discussed today is in that app, hemodynamic app. Our understanding FFR, IFR, RFR, microvascular disease, all of the above. You see the center, you see the logo is H. Okay, H is hemodynamic, and you see your waveforms. So this was a post-optimization, malapposition. Look at the malapposition which Kiski mentioned, less than 0.04. And we were just above that. That is why we went back and did the post. So we have concluded today's case. If we have any questions for us, go back to him. Yes.
That was. Are we doing another quiz question there, Dr. No.
No.
That was fantastic. I think we hit most of the questions from the audience. You know, I would put another plug in for the apps. So much of this is iterative learning. It was a great demonstration of executing the OCT, but you really have to see the images, and it's such a great resource to do that. I would stress to all the audience members. But short of that, it's a wonderful case. Thanks so much to you, Dr. Kinney, all the members of the team. Thank you all for joining us today for this exciting case. The recording of this case
Can I discuss?
will be.
Okay,
you want to add something here?
Yeah, Kiski wants to show some imaging.
So today's point of the proximal LED lesion. Can we show the OCT?
He wants to show the proximal LED OCT again.
We defer the lesion based on the IFL because the IFL negative, but based on that, like a future topic of the vulnerable plaque PCI Pluvian trial and the Prospect 2 trial, our lesion of the proximal LED tightest area based on the OCT is actually less than 4, like 3.5. But plaque burden I measured, it's like less than 70%. And there is some lipid plaque, but not thin cap. So it's not TICFA, and we don't have a LCBI based on the NIRS. So the Pluvian trial should be based on at least 2 criteria from that 4 FFR negative. So even this one doesn't meet that criteria for the prevent trial. So, but if we find a TICFA and less than 4, it's gonna be the criteria for the prevent trial. It's not endorsed by the guideline yet. It's more and more trials coming based on the Dr. Kinney's presentation. So the future, like direction of the vulnerable PCI, that is the next topic based on the intravascular imaging. So.
No, that's a great point. I think in that trial also, the majority of the patients enrolled with those anatomic criteria, the area and the plaque burden.
Mostly,
but no, it's a good example of a potential mismatching lesion. So thanks for showing that last image, and we'll stay tuned on what the rest of the data says in the ongoing trial. So. All right, with that, well, we will wrap up. Again, thanks to all you. Thanks for joining us. The recording of this case will be archived on ccclivecases.org later today. Intravascular imaging live will occur every other month, and we will let you know about upcoming cases, of course. We do know the next case will be on Friday, December 5th, so put that in your calendars at 8 a.m. Eastern as always. That wraps it up. Thank you all again for joining us, and have a great weekend. Take care.